and briefly and introduce to the community health network assessment approach. Next slide, please. Which is a practical tool to design to support data-driven decision-making at community level. And local health systems are facing increasing pressure, limited resources, rising chronic diseases, and persistent social disparities. And at the same time, health is no longer just a medical issue. It is a key driver to community development. However, in many cases, decisions are still fragmented and not sufficient data-driven, and this often leads to a mismatch between what people actually need and what the system is able to provide. To address this, we use the CHNA approach, Community Health Network Assessment. It provides an objective, evidence-based picture on population needs, available resources, and existing gap. And the goal of this tool is to shift from fragmented actions to coordinated system-level health management. Next slide, please. And please let me briefly show how this approach works in practice. Very briefly, this tool helps transform fragmented data into actionable insights. It provides a comprehensive picture of population health and available resources. At the same time, it identifies gaps between needs and system capacity, and it supports prioritization in evidence-based planning. In simple terms, CHNA helps to move from intuition to evidence-based decision-making. And next slide, please. This slide introduced to the CHNA approach as a practical tool to support system-level decision-making in community health. The key objective is to move from fragmented interventions to coordinated system-level management of community health. In many settings, decisions are still made on silos. CNHA helps to align them within a single analytical framework. And what CHNA is, it is an analytical framework designed to support evidence-based planning and management at community level. The first component is community profile. We analyze the community profile, including population characteristics, demographics, environmental determinants, and vulnerable groups. This allows us to understand who the population is and what drives health needs. The second, we assess the service delivery system, focusing on availability, accessibility, and distribution of services. This helps identify where the services are aligned geographically and functionally with population needs. And the third, we evaluate network capacity, including workforce, infrastructure, quality of care, digital systems, and governance. This shows what the system is actually capable of delivering. And by combining these three components, CHNA generates a comprehensive overview of both health needs and available resources. And it helps identify mismatches between demand and system capacity. Most importantly, it supports prioritization and evidence-based planning on the health service network. Next slide, please. And you will see, I will demonstrate how data will be transformed into decisions. And what I would like to say is that we use three indices which reflect three levels of healthcare system readiness. The first index focuses on awareness, whether the community and local authorities understand their population, health needs, and available resources. Without this level, planning remains fragmented and reactive. The second index assesses whether the system is ready to deliver services in terms of availability, coverage, and alignment with needs. This is where we evaluate how well services match population demand. And the third index focuses on capacity, the actual ability of the primary care network to deliver services sustainably. This includes workforce, infrastructure, and system results. Importantly, these indices should be interpreted together. For example, strong capacity without proper awareness may lead to inefficient resource allocation. Conversely, good understanding of needs without sufficient capacity limits implementation. In this way, these three indices provide a practical framework to assess system readiness and guide prioritization. On the next slide, before we move into mapping, next please. I would like to briefly show the level of data we are working with. You see that it is a standardized data set across settlements, including population and service access indicators, distance to health care facilities. The first two columns, it's ambulatories, and number in two, and the sixth column with number 2 also, it is Felcher point, medical points, FAPs. And column number 3, marked as 1, demonstrate distance to health facilities, and column number market number 3 demonstrate number of people living in number of population in each settlements. And this is structured data set at the settlement level, covering access, infrastructure, and service availability. This is just to demonstrate a small portion of data that we have, because all the same representation of data with vulnerable population, the deviation by vulnerable groups, but by age groups, etc. And this level of granularity is critical. It allows us to move from general assumptions to precise location-based decisions. Based on this data set, we can visualize inequalities and service gaps across territories. And next slide demonstrate 10 gramadas, municipalities that we just example. And we try 9 of them have been made by hand, and in the second row you will see first Gramada, Zhashkiv Gramada. We use GIS technologies with mapping to decision making, like GIS in action, like Zhashkiv case study, and applied for accessibility analysis and service network optimization. And this case, Zhashkiv case, used to analyze accessibility and to inform service network optimization. And this is where data translates into planning decisions. And this approach is scalable across communities and regions. And next slide demonstrates results of the CHNA process. Each community receives a structured analytical package for evidence-based planning, identification of priority gaps, targeted resource allocation. And you see different approaches we demonstrate, including prevalence of disease and morbidity level. And you see these radial diagrams shows different, like composite indices of profile of Gramada, population profile, and services profile, availability of resources, availability of different type of care at Gramada level. And this is not just a report. It is a tool for decision making, and it supports evidence-based planning, identification of priority gaps, and targeted resource allocation. The package includes a full community health profile, service coverage assessment, capacity analysis, and integrated indicators. And importantly, this approach is standardized and scalable for broader implementation. And finally, next slide, please. I would like to say that CHNA provides a practical way to connect data with decision making. It enables communities to better understand needs, identify gaps, and plan to targeted interventions. We see strong potential to scale this approach and integrate it into national system. And we would welcome collaboration with WHO to further develop and scale this approach, like from data to decision and from decision to stronger health system. And we are ready to scale, ready for integration, and ready for impact. Thank you.
Now I change the language maybe in English, yes?
Yes, English, please.
Oh, let's start.
You can see what kind of gramadas have been involved into completion of information and provision of information about gramadas, and you participated in assessment. And the final column, like dashboard, demonstrate the completeness of data entry. Следующий, next, please. Дальше показывайте. And you see that all questionnaire, like let's say, all tool consist from 19 sections. 19 sections, and each section has some subsections. Therefore, we are talking about composite indices and provide comprehensive information like radar diagrams. And also we see at this slide, we see by section and subsection completion of data. Next, please. And all communities can, when they receive this tool, the initial data dated by 2022 include all settlements and number of people which lived in 2022, and completion of this next columns. Each gramada, each community can observe changes in population, in not only in population but size, but also in composition of population, number of children, number of adult population, etc. You see that this is distance from settlement to healthcare facilities, distance to community hospital, to ambulatory, to community hospitals, and condition of roads to analyze what kind of this is availability of public transport, and it is a problem within most of communities we recognize. Next one, please. Also, we ask them to complete, do they have school in this settlement, and do this school have medical office in the school and medical staff, and to analyze it and to understand how medical staff of school communicate with primary healthcare doctors to to monitor health, child health and problem with health and how they can support in school, because in schools. Next, please.
Sorry, so this information from the government of the city. Yes.
Mm-hmm.
The next.
We also identify, not we, but Gramada complete all this information, not we, about availability of medical points. Why we are talking about medical points? Because you explained that legacy of Soviet Union, we have very network. We have network mostly composed on FABs instead of primary healthcare facilities like ambulatories, and this is a problem. But it is non-physician, but they are working as assistant, like assistants of primary healthcare physician, family doctors. Therefore, I think we have to use this resource for monitoring, especially for non-communicable disease, and we recognize that one of indicator from antenatal care, like maternity deaths, yes, increased in Ukraine. So I think that it is trouble, and we have to look deeper what had happened. It is not just war, but about service delivery. Because during completion of this tool, we recognize that antenatal care is the problem with accessibility just only in primary health care or centers in the center of Gramada, and most of pregnant women do not receive regular services. So such indicators like number of visits during pregnancy, etc., all these indicators have to be monitored because we have to reduce problems with mother and child health care problems. Okay.
Yes, this information from the primary health care center. It's information.
Okay.
Yes.
The primary health care center also provides a type of care that they can provide to population. Do they have special transport to, for example, to move like mobile teams or move from like based on FABs, they can organize visits or to work with people. For example, in Facebook, I have had there were one publication where gynecologists moved to remote villages and help all women. And this is services, okay, special vehicles at primary healthcare level, availability of telecommunication technologies, because now if they have communication technologies, they can use telehealth, for example, and it will improve availability. This is long list of 18 indicators. 18 sections, and thank you, Sergey Alexandrovich, for demonstration. It's availability of pharmacies. It's huge problem in all these municipalities. Only 1-2 pharmacies they have, and only 1 or 2 of them are working on Доступные леки program. So we can say that medicine is not available to population because in other countries, in Kazakhstan and Kyrgyzstan, when we ask population why they do not use medical benefit program scheme, they said that we have to pay co-payment for the medical reimbursement plus co-payment. This co-payment not exceed travel costs. So travel costs exceed reimbursement, so we do not need in these medicines, we cannot, it is not useful for us. The same situation in Ukraine. So we have to think how people with non-communicable disease, with chronic conditions, can improve the access to regular medications. Okay, just one example. And this is demographic structure of population. This is sections, 18 sections, including palliative care, including rehabilitation, emergency care, mental health, all type of care that can be that should be provided at community level, and at least to provide information if they have no such services, cannot provide deliver such services, where population can reach such services. And we recommend to municipalities, to local self-governments, to improve transportation to such facilities and to organize this. So it could be different ways to implement, for further implementation, for prioritization firstly, and after that to implement and for investment, for example. Okay, this is just very briefly